Good evening, everyone. My name is Quavis Peacock, and I want to welcome you to Envisioning Equity. This moderated panel discussion is the first of a series of quarterly gatherings where we hope to provide a space for Wacoans to come together and to discuss disparities in areas of health, education, economic development, and criminal justice. We decided to start with health, given this time of COVID, and because it is a topic that affects us all. We are proud to partner with Baylor's Center for Community and Church Impact, and we are proud to have you all on this call today, where we hope to provide with you with topic and knowledge and information that will help you to envision equity. Before we get started, there are a couple things I want to share. The first are some event reminders. This event is presented in webinar mode where you will only be able to see the panelists and presenters. Your video and audio will remain muted throughout the session. Questions may be submitted through the chat function. As this is presented in webinar mode, you will not be able to see discussion within the chat. And lastly, this event is being recorded, so where only those presenting will appear during the recording. As we talk about envisioning equity, there are several definitions that are too often confused, and we want to make sure that as we move forward, we have a clear understanding of what these definitions are. The first being diversity. Diversity is the presence of differences that may include race, gender, religion, sexual orientation, ethnicity, nationality, socioeconomic status, language, age, or even political perspective. The next definition is inclusion. Inclusion is an outcome to ensure those that are diverse actually feel and are welcome. Inclusion outcomes are met when you or your institution and your program are truly inviting to all. To the degree to which diverse individuals are able to participate fully in the decision-making processes and development opportunities within an organization or group. And then lastly is equity. Equity is the topic we want to discuss today. Equity includes the elimination of policies, practices, attitudes, and cultural messages that reinforce differential outcomes by race or fail to eliminate them. Equity is promoting justice, impartiality, and fairness within the procedures, processes, and distribution of resources by institutions or systems. Equity is the condition that will be achieved if one's racial or even their gender identity no longer predicted how one fares. When we use the term, we are thinking about racial equity as one part of racial justice, and thus we also include work to address root causes of inequities, not just their manifestation. Tackling equity issues requires an understanding of the root causes of outcome disparity within our society. It is through the Envision Equity series that we hope to gain a better understanding of the root causes of disparities within our system and discuss possible solutions for eliminating them. In order to do that well, there are some particular data points that we want to share with you all, just so we can get a better understanding of some of the disparities that are currently within our community. The first looks at our inability to access healthcare. As you will see in the very center of this particular map is Waco. And as we look at Waco and the eastern and southern parts of the city, at least on Waco standards, of course, more people have an inability to access healthcare. Next, when you think of access to healthcare, you oftentimes think of insurance. And where when you look at Waco and Clinton County and Texas as a whole, people of color tend to be not insured as our white counterparts. Afterwards, a disruption in insurance. While you may have it for a period of time, people tend to see a disruption in it for various amounts of reasons. Unfortunately, this disruption in insurance is seen more prevalently in our parts of Waco that are traditionally home to our people of color. Again, South Waco, East Waco, and North Waco. This data all boils down to this last point that looks at disruption to healthcare access by race and ethnicity. Whereas, unfortunately, our Hispanic and African American communities tend to see this disruption more often than white counterparts. And it's the issue that we hope to discuss further here today. To help in this conversation is moderator Tiffany Gray. Tiffany Gray is a mother, an advocate, a friend, and she serves as the Senior Director of Health Initiatives for Prosper Waco. We're happy to have Tiffany to lead this conversation with us today. And we thank you all again for joining us for Envisioning Equity.
Thank you, Cuevas. This is such a timely conversation for our community and for the broader nation. Good evening, everyone, and thank you for joining the Envisioning Equity panel series hosted by Baylor's Office of External Affairs. Tonight's segment focuses on equity in healthcare, and we're joined by a distinguished panel of guests who each bring a unique perspective to the work of advancing equity in health outcomes. Please help me in welcoming Mariela Gutierrez, Dr. Ileana Newman, and Paula Solano. Mariela Gutierrez is currently a population health sciences doctoral student at the University of Texas Medical Branch. She graduated from Baylor University with a bachelor's degree in medical humanities and her master's in public health. Her involvement in Waco consists of serving as a community health worker for the McLennan County Public Health District and being active with her local church. She's passionate about how data can help us understand the importance of minority health. Dr. Ileana Newman trained for family medicine at the University of North Carolina, Chapel Hill, and did a fellowship in surgical obstetrics. Her career has been dedicated to the care of underserved populations. Currently, she practices at Family Health Center and is a faculty physician in the Waco Family Medicine residency. Paula Solano is a Master in Public Health student at Baylor University, presently employed with a health plan serving children and young adults with special needs. She holds a Bachelor's of Science in Business Administration and is a certified community health worker. A Waco native who is passionate about serving her community, particularly our underserved and represented citizens, Paula Solano. Thank you all for being here today and engaging in this important and timely dialogue. Why don't we just jump right in? So often we think of access to care as the financial ability to seek care, that physical access to be able to transport and get that transportation to care. But could we offer up a broader, more comprehensive definition of what access to care means?
Absolutely. So, you know, it's really interesting. We started with the slides of insurance, and that speaks somewhat to people's socioeconomic status, but access to care also means being able to have the time off from work to go see your doctor. It also means that once you've seen your doctor, that you can afford the medications that they prescribe or the treatments, whether that's physical therapy. That's something that I often would find useful for my patients. Some of my patients do really hard physical labor, have injuries that would be very, that would work well with physical therapy, but finding time to see a physical therapist and paying for one are both huge barriers sometimes to care. And access to care also has to do with being able to find a physician that you can connect with, that either speaks your language or that culturally is appropriate and being able to connect with you. One of the things that we teach is that, you know, in general, we have about 15 minutes with our patients. They have 24/7 the rest of the time. And so part of our big job is connecting with them, teaching them how to do self-management of disease, how to be able to follow through with treatment plans. And if we can't have a relationship with a physician that we can, that relationship that continues to build on healthcare, then your access to healthcare is also impeded.
Other barriers that I have seen with access to healthcare is understanding how to navigate a system, how to access a service, how to advocate for yourself, for your loved one. There's often the fear that you can't seek care because of your inability to pay and or because of your legal status. Sometimes, while our Hispanic community is very notorious for waiting until the very last minute, you're very, very ill, and or seek the emergency care as your primary source for healthcare. So it's helping our communities better understand the value of establishing that medical home and having that relationship, knowing that the staff is trained and they speak your language beyond the English and Spanish. There are accommodations to help others, but really, really diving in to understand the culture, each unique culture, and those barriers that we have within each microculture, essentially.
Mhm.
And I also would like to add that in addition to all of the factors that we've been discussing right now, something that we forget about access to care is that access to care also comes within the community, meaning the community needs to feel empowered that they can seek a doctor and establish a relationship with a doctor. And so when I think about community empowerment, I think about health literacy and how much the community knows about their health and wants to do something about their health. And I believe that part of the role of healthcare workers and public health is to contribute to that empowerment in some way by health education or increasing health literacy. So I think that's another important component of access to care that we sometimes oversee.
I heard several things there, whether it's the ability to self-advocate, the ability to understand, even community empowerment. What are some tools and strategies that we can employ to help build that health literacy and build that self-advocacy, that working that muscle? What are some ways we can do that?
Yeah, I believe that it's a partnership between the community and, like I said, healthcare workers. So a doctor, a nurse, a public health educator. I think there needs to be a partnership between both parties and willingness to collaborate to increase knowledge in health. And I know we're going to talk about community health workers in a little bit, but I often see community health workers as that bridge between those two parties. But having that relationship between both sides of the story here, so the community and healthcare workers.
I love that, and that's a perfect moment to shift gears here and talk about that connection between clinical care and public health, between the medical model and the public health model. We've got public health practitioners here, medicine here. Talk a little bit, Dr. Newman, about how we can leverage public health, leverage the clinical side, and bridge those two worlds together.
I love this conversation, obviously, as a family medicine doctor and someone who's been mostly working in community health centers. My first job was actually with migrant farm workers. And so somebody who does this kind of work, I see the relationship between public health and medicine very integral. Like I said, physicians have about 15 minutes per appointment, and people's lives go on much longer than that amount of time. And so building good relationships with, for example, community health workers, the public health district, and those sorts of things to maintain structures that are going to keep people healthy outside of the office are important. But let's not forget that part of what this conversation is also about is the fact that people can't access like immediate care for life-altering situations. So I often end up seeing patients, having to take care of patients in the hospital who are diabetics because they couldn't afford their insulin, or people end up on dialysis because they couldn't come in to take care of their blood pressure until their kidneys failed. And so even though I definitely value that relationship and want to bring this more integrated healthcare, where one of the things that we did a lot in North Carolina is really work on this team approach where team care of patients, where you have social workers and mental health and pharmacists and physical therapists and everybody kind of working together for the betterment of the patient. But I think at the moment here in Waco, we're still far from that in terms of people are just not even getting basic prenatal care, basic well child care. I had a well child visit today of a 7-year-old who hadn't been seen for 3 years. Mom said she just hadn't been able to take time from work to bring the child. Those are really important years that I need to be able to see them, make sure that their development is going okay, their hearing, follow up on their nutrition. And I missed 3 really important years of that child's life. So advocacy is important and empowerment is important, but there's also right now lots of barriers that are preventing people from just getting basic, important, life-changing care.
Thank you, Dr. Newman. We do talk a lot about insurance coverage. If you think about the Robert Wood Johnson Foundation's framework for access to care, insurance coverage, having that medical home and relationship, availability of providers. But I'm also hearing additional social barriers that you talked about with the type of employment, the ability to take off work. What are some things that the business community, the local community, what can we do to modify that type of condition that is preventing people from accessing care?
Well, that's such a great question, specifically here in Waco, because it was actually the business community along with the hospitals and other city leaders that came together to make sure that we did have primary care in Waco, and it was kind of spearheaded by the McLennan Medical Society along with businesses and the government, local government, to start the family medicine residency program here, which is the reason that we do have actually a fair number of clinics and in our training primary care doctors that can build those relationships and teach and help patients empower themselves. And I think that was such a good model, and I hope that we continue to focus on those triumphs that we've had in the past of joining together forces at all levels of society to say that primary care is important. We know that in places where primary care is prioritized, that those communities have better health outcomes, and making sure that people, looking at our transportation systems, finding ways in the school and other ways of communicating with families about the importance of early childcare, about the importance of early prenatal care. So it takes businesses and government and our local health community to continue to give patients those messages and to have these conversations where we figure out where are some of those barriers and how can we start overcoming them.
In addition to that, I would like to say that at the policy level, there's a lot that we can do with businesses, within a business, encouraging a healthy workforce, for example, policies that could incentivize for that type of movement. And with COVID-19, even now, this is becoming of greater importance because we've seen that a lot of I did some contact tracing work for the state, and a lot of the times when we would conduct the contact tracing and we would ask that question about, have you been at work while infectious? A lot of people said yes, and a lot of the time minorities, because they couldn't take time off or they just simply didn't want to sacrifice the time from working and then having to take care of their families. So at the policy level, there is a lot that we can do, that we can, have conversations with businesses about establishing healthier workforces and improving health within their workers. But that's something that, needs to be discussed furthermore.
Oh, thank you, Mariela. And we have someone from the payer side on the call. Paula, did you have any comments there?
Yeah, and so thinking a community, on a community base, there are initiatives, the employer workforce, or I believe the health department has a program where employers are incentivized for promoting health and wellness within their places of business. This is small to big and everything in between. And it talks a lot about physical activity and things like that, but this is a great opportunity, especially right now with COVID. It's a great teaching moment for all of us to be healthy and be aware of any symptoms we may be having, and then really trying to avoid that contact with people if we're facing any symptoms. Yes, so I think that there is an opportunity on a community level to educate, but also, as Mariela said, on that policy side, in incentivizing our businesses to encourage health and wellness, potentially beyond physical activity, in more about having your annual exams and having a medical home. So I really think this is just a great opportunity for us to dive in and support and be innovative in the work that we're doing here.
Thank you, Paula. Very good. You mentioned the importance of educating communities at multiple levels. And we hear so much about culturally appropriate messaging and having to think through multiple segments of the community, segmenting a message around COVID, for example, or a message around the importance of the annual Well Woman exam. How does messaging impact healthcare access, and what are some ways that we can better reach health populations that have historically had difficulty accessing healthcare?
I think what you just said right now is super important in terms of that the messaging needs to be appropriate for the community that you're trying to serve. And I think, some of the messaging that I sometimes see is more kind of focused on, you see like having people be playing in a park, and understanding, being able to focus a message both linguistically and culturally to the communities that you're trying to serve is something that in public health has shown evidence of some benefit. But then also once people get here to the doctor, they need to be able to feel welcomed. They need to have, we had just been reviewing that some of our patient education material that we hand out is at a 10th grade reading level. We just did a check of some of those, and that they need to be at a 4th grade reading level for the majority of patients. We also recognize that some of our patients are hearing impaired or visually impaired, and that we actually have a significant portion of our patients that are illiterate and can't read at all. And so giving them a piece of paper with instructions is useless, and figuring out how to do, for example, education on diabetes with graphics and pictures and things that are easy for people to understand and follow and tape on the refrigerator are some of the kind of patient-centered things that we can do to help patients feel welcomed and to be able to follow through with the things that they need to do to stay healthy.
Dr. Newman, that is so exciting to hear about graphic communication and patient education and teach back. Very, very exciting there. Paula or Mariela, any comments there?
I do think that as a community, we need to continue to educate and normalize the conversation about preventative care for women, knowing that you really should have your basic health screenings annually as young adult women and beyond, and not wait until they, find out that they're expecting, thinking about health screenings before that happens, thinking about just planning in general, but health and wellness. So we need to normalize as a community that it's okay to go have an annual exam. It's okay to have an established care with a medical home. It's okay to do that before you decide to start a family, before you find out you're starting a family. So I really think that as a culture, we need to continue to cultivate those conversations so that we know the value, so that there are programs out there to support and increase that access, but it's just normalizing that conversation right now, because it's still a big stigma to go and seek access for preventative screenings.
Now, Paula, you've really touched on something there when talking about normalizing seeking preventive care. And I'd like to hear from everyone around the issue of reluctance in seeking health care. Of course, there may be financial concerns, but we've also heard about concerns about hearing something negative. Can we talk a little bit more and unpack what some of those reasons for reluctance in seeking care might be?
So it is true that sometimes people, and I think we're seeing a little bit of it even now with COVID, where I've had several patients refuse to be tested. They'll call and say, hey, they have symptoms that are concerning to me, and I'll ask them to come in. We do testing same day, get results back in like 15 minutes to an hour. And I've had some patients that have not wanted to because they are afraid of what am I going to do with the answer. You know, then I have to miss work, then I have to tell people that I've been in contact with. And similar things sometimes we see when I'm concerned about somebody's, you know, I'm doing a screening test and that may be positive for cancer, or people don't want to do a mammogram because what if it is abnormal, and what are the consequences of that? So understanding that it's not just about that when you do seek healthcare, that sometimes will bring, it's almost a question that you ask, and that the answer is sometimes more things that a person is able to manage, and trying to understand how to provide the support so that people don't feel overwhelmed when given a new diagnosis. Diabetes is definitely one of those diagnoses that people feel very overwhelmed once they're told that they have that, especially with diabetics in their family and who may not have had good outcomes. They can see it as really negative instead of something that can be managed. And that's where health education comes in again.
Awesome.
I totally agree with you, Dr. Newman. Building that support for the patient after they leave the doctor's appointment is very important. And if there could be ways that we could build that support system outside of a clinical setting, I think that's where public health should also invest some time into looking at that. And I know there's ways like social workers or community health workers that could be that support system where community members can rely on and kind of use as accountability partners. I know other places where that could serve as support systems for underserved communities are, for example, faith-based organizations, a pastor that they look up to, or somebody in their church that kind of can be that partner that works with them in terms of their health needs or questions, sources of information where they can find the right information. And so, yes, building those support system outside of the doctor's room, and that's very important.
I think
Thank you,
one of the,
Mariela.
sorry, I think one
go
of the
ahead.
challenges that are, I think often faced is that there's so much information coming through in the media. So finding that trusted source, and then understanding who's communicating what, because it really is very alarming. I've personally seen when a person has been informed that they were exposed to someone who is positive, someone who has passed with COVID, and just feeling that immense sense of fear of wanting to isolate and then not knowing how, and then kind of walking them through that process that, you know, perhaps you were exposed. However, let's look at the steps. Do you have any symptoms? Having that conversation, it's so important for our community to have that person, that person that they're going to communicate their fears, that's going to help them walk through the process. And faith-based organizations are often that place. I can think of my place of faith, St. Francis. They continued services once they were allowed, and they really, really educated and provided the PPE and the hand sanitizer, and had teams of, you know, cleaning the place following a service, but communicating to the participants why they were doing this, why it was important to have a face covering, providing this for them to take beyond a service. So it's really wanting to take a closer look at what is that support that a person has, because it genuinely is so overwhelming. And as our numbers just spiked up earlier, you know, it's thinking, oh my goodness, you know, who's going to be next? Am I going to be next? And how can I prevent that? So it's a big teaching moment, I would say, for all of us.
Thank you all. I've heard a couple of things there. First, obviously, leveraging community institutions and honoring the reach that they have and the respect that they have. I've also heard with a couple of our responses and alluding to the duties or some of the functions of community health workers. But can we take a pause and just unpack or define what is a community health worker and where might they fit into the access to care equation if we're looking at advancing equity?
Yeah, I can help with that, define that. So a community health worker is a person that's trusted in the community that kind of steps up and contributes to the community in terms of health. So it can be anyone from the community that decides, that my community needs to be empowered in terms of health and all aspects of health. It could be managing chronic diseases or just wellness in general. So they serve as a bridge between the community and the healthcare system. So they're often also known as resource navigators because that's what part of the community health worker job is, to disseminate where the resources are for the community. And as we know, health is very comprehensive. So it's not just about looking for a clinic to go to, but there's other resources that are needed as well, social resources, anything, all the social determinants of health. So that's what a community health worker does. They bring in to their communities what's outside in the system, but they also serve as a voice within the healthcare system, like an advocate of their community within the healthcare system.
Right, and so the concept of community health workers has been in existence for well over 20 years. They're very common in the larger cities or border towns or even outside of the United States. For my place of employment, our team consists of community health workers. So we are community health workers. We have that lived experience. We live within the communities that we serve. There's a big emphasis in learning how to navigate that system. And also how to inform ourselves to help families walk through the process. It's very simple to tell someone, we'll call XYZ, they can help you. But it's that simple, taking that step, that first step becomes such a task for people because they're not used to it or because they're not familiar with. And that small barrier can impede a person from improving their overall quality of life. And so just helping that community member with navigation is a key piece, and it makes night and day. It's a big difference between giving someone a phone number and walking them through that process. So I do see much value in having a community health worker initiative strengthening this collaboration within our communities.
Hearing a lot about building that patient confidence too and their efficacy. Dr. Newman, you wanted to add to that?
Did, and I kind of want to say how much I appreciate what Mariela and Paula are saying. It's so important, and I'm a big advocate for community health workers and have worked with them before. But I kind of also want to shift the conversation a little bit, only because I think a lot of what we're talking about right now has to do with patient education, patient advocacy, and those things are important. And I think it's actually, healthcare in itself is a really kind of overwhelming system, even for a physician. When I'm sick or when I had to deliver my babies, you feel very vulnerable when you're in healthcare. It's just kind of overwhelming and bulky, and it doesn't make a lot of sense. And I think that that's true for everybody who comes in contact with the healthcare system, and we need to make it better for everybody. But I think what I feel the bigger urgency about right now, and what I am hoping that we continue to touch on, is the fact that our outcomes are really different depending on your race, and that there isn't any biological reason for that to happen, that there's structural issues in our society that go beyond a lot of public health efforts that we have put forth. For example, in women's health, we have 20 years that we've been trying to close the gap between outcomes in African American women and the population as a whole, and we've made very little progress despite really a kind of focus public health efforts. Why is that? Why are we having such differences in outcomes? The Latino population is about 20% of the population in Waco, but at one point we were 50% of the COVID cases. Why is that? We're also the bigger number of deaths, Black and brown deaths throughout the country. Why is that? And if we think about, we can't ignore the fact that there are racial inequities, not only in healthcare, but in the other settings that contribute to our ability to take care of people's health. And not, and I just felt a need that we needed to bring that back up to the forefront and not forget that behind just, I worry about is putting too much of the burden of improved health outcomes on patients, and then learning more and addressing their issues more and figuring out ways. You know, we need people to have a place at the table, the people that are making decisions about healthcare, the people that are making decisions about jobs, schools, and why our kids are not having the same access to the kinds of jobs where they can take paid time off to go to the doctor. And so there's a crisis right now where we are having just a disproportionate number of Black and brown people that are dying from COVID, and there isn't any medical reason for that to happen. And so I want us to continue to think about the systems outside of what we do in healthcare as well, that are going to be important in reducing some of that inequities, and we can't ignore the place that racial justice takes in that.
Absolutely. Thank you, Dr. Newman, for underscoring that. We have talked before about what are those factors that influence health outside of the medical office, because you've mentioned before that medical encounter is so brief compared to the rest of life, the rest of working and worshiping and playing and living. So what is it about the conditions where we live, work, and play? Any thoughts from you, Mariela or Paula? Well, let me just clarify there. So in thinking about, employment conditions, school conditions, neighborhood and community conditions, what are some changes that we can put in place or even begin to advocate for that can improve health outcomes?
Well, I would say establishing that health is a priority, and because I feel with minority populations, health is sometimes not the priority. You're kind of in survival mode, and so you put health at a side. So that involves, there's a lot of interpersonal factors that should be addressed if you want to address that issue. But maybe, yes, because sometimes as minorities, we think that, okay, health is a luxury, or, when I get sick, I'll take care of my health. But it's like I think Paula was mentioning, that preventative health is as important as going to the doctor because you have a problem now with diabetes or hypertension. But bringing that message back to our communities that preventative medicine is as important. So if we can disseminate that somehow, not just within communities, but in school, the school system or business system, that I think that message would definitely improve the inequities that we are seeing nowadays.
Yeah, so I definitely think it is a challenge, and it's circling in my brain how we can shift the way we're thinking, specifically as a Hispanic Latino community, to take care of yourself, to take your prescriptions as prescribed, to increase physical activity, to monitor your nutrition, to be more aware of it. It's a very interesting dilemma that I think it's so much more than anything that we can unpack right now, because there is that fear, and because I personally know that healthcare is a luxury. It is when you fall between the cracks as a youth and you're not covered by health coverage, you don't grow up going to the doctor annually for a well-child exam. And so then we can connect and understand why people don't seek primary care, why they don't establish care, because we've experienced it as well. But it is something that we've had to shift as we have been in the settings of health and social services. But changing a person's ways when they're an older adult, I think is a very, very big challenge, even though you encourage them to take their medications as prescribed, to not skip a dose and not, uh, brace to improve their health weeks leading up to that appointment. Um, it's a challenge, to say the least.
You know, earlier Dr. Newman mentioned we've talked a lot about at the individual level and at the patient level, some of the things that we can put in place and some of those barriers. But then Dr. Newman, I appreciate your conversation about those structural issues and how we as a community can work to address those. And of course, COVID-19 really highlighted longstanding equity issues with historically marginalized communities and in communities of color. It certainly put a spotlight on essential workers and the conditions of essential workers, the ability to take off work, as you mentioned. And of course, many of us probably really sensitive to childcare workers and so many others who have been really carrying such a weight for us as a community. What can we do locally? I think you mentioned the long game of changing educational opportunity and trajectories, but what can we do more immediately and very locally to address those issues around healthcare coverage and being able to take off for sick leave, things of that nature?
So I think that you're completely correct in reassessing the fact that COVID has brought out a lot of the inequities that were already existing. My concern actually is that it's actually going to worsen them if we are not careful for the long run. For example, people who did have insurance may not have it now. People who did have jobs won't have any now. My apologies. Some of our kids, and when we are talking about school, some of our kids are, so sorry, are not accessing education the way that they need to. We see with maybe someone else can pop in for me for a second while I catch my breath. This is just so exciting.
It sure is, Dr. Newman. Go ahead and catch your breath there. Mariela and Paula, we have had conversations both offline and here in the office around kind of a gap that we expect to see, unfortunately, but one that we do expect to see because of this change and rapid change in modification in the way that children are accessing school. Is there going to be kind of an education gap or lag, but also in parents who are now faced with unemployment, where formerly insurance was employer sponsored? So what can we think about? What can we put in place? What are you hearing as far as strategies that we can begin to employ to create another layer of a safety net, if you will?
So I was in a conversation today. It was a networking opportunity talking about our current situation across the board. And one of the agencies said, people aren't going to come in for one-time assistance. This is in it for the long haul. We need to strengthen our forces and think beyond temporary one-time assistance. We need to think about building our programs where we can help these families with needs, and it was spanning with auto insurance, auto payment, internet to homeschool children. How much can we help them? And then recently a conversation about technology and accessing primary care. So these are all conversations that are happening, and one that I took a little further with two health plan colleagues that I have, and it was very much a, we'll look at these situations on a case-to-case basis. If the person needs it, let's see what the provider is saying. What is so really turning that attention to the medical home, because we want to increase access to those services. But right now, our community, and it just continues to fluctuate. That need isn't the same for this group of people as it was in April. It is changing, and so we as a community need to look at that and help our communities, because it essentially, this is crisis mode. And perhaps, yes, you are giving them $2,000, but they are so far behind with what they owe in their expenses. They're trying to catch up, and that's not going to stretch. So we as a community need to think a little bit harder and strategize in providing that safety net. And really those dollars right now for our families, at least the families that I serve, there's a great need. One of the positive observations that we made in this conversation was that pantry resources, wonderful. We have them in abundance. And one of the pantries present was saying they have not seen an excessive amount of utilization with their pantry resources. So that told them that our community, that community specifically had that component covered. They weren't seeing that frequent visitor because that community specifically had pantries available to support that need. So those are a couple of the observations that we're seeing here in the community.
Paula, I want to circle back around with something you mentioned around technology. Obviously, there had to be a rapid shift in switching over to telehealth offerings, and so many medical providers accelerated their timelines with rolling that out or making that more widely accessible. But what about segments of the community that have difficulty in accessing either a device or internet connectivity? What role does technology access have in either widening barriers or closing that gap?
I definitely don't think it's closing the gap. With the population that I serve, it's our medically fragile population. So right now, most of our parents are choosing to keep their children at home. And it really isn't, we're keeping them at home. We're not going to our well child exams, and we're encouraging them to reach out. If you have any symptoms, reach out to your medical home. Don't take that option off the table. I have personally connected with parents who only have the telephone that's issued through their Medicaid, essentially. And so that's a very, it's the older model cell phones. It's not a smartphone. So then they don't have access to telehealth. And that's where those conversations began with what else can we do? At the time, the family did opt to go in to see their provider, but I definitely think it's creating a gap. It's creating a gap with health and with education, because while it may seem very, very simple to navigate because we are experienced with those platforms, or because we're so vested in trying to learn it, but it really is so overwhelming. And each person will encounter their own unique set of barriers when they're trying to navigate. And I smile because I've encountered them as well with homeschooling. And so it's about being persistent, but so many of us don't have time to figure it out. And so technology, it really is creating a barrier, in my personal and humble opinion. It just is.
Thank you, Paula. I want to give each of you an opportunity to say any final thoughts or closing remarks before we open up for Q&A from anyone who's tuning in to the virtual panel. Please feel free to submit those questions through the chat box. Paula, I heard some opportunities to create some actions and develop solutions around that technology barrier there, but any final thoughts from the panelists around solutions that we can employ, or just thoughts to keep in mind as we continue to work on this issue?
I would say that our current situation with COVID-19 definitely has taught us that we're going to have to find innovative solutions that we've never tried before in the past. We're going to have to be very creative. And if you're a business, or if you're part of a healthcare network, or work in a clinic and you're a leader in our community, finding innovative approaches to reach our community. It's needed, and I would say that hopefully we're learning from what's going on right now. And just as a final remark, something that I've always thought that would be contributing to reducing disparities is that we always need to go back to our communities. And we're all, I guess, people in this panel and outside of the panel, we're in some way kind of leaders in our community, but we also have to make sure that we are bringing that voice from the community, and what is that will work for them. They have to be informants if we want to provide solutions, the solution sometimes comes within the community because they have ideas too, and they can tell us what works, what's been working for them, and support those ideas, and have listen to what they have to say as well.
So I would just briefly say, I many years ago mentioned to Dr. Newman, encourage her to continue to be the voice for the voiceless, is what I said to her. And so we have to continue to advocate for those who are not at the table, for those who are not represented, for our vulnerable populations. I would love to thank Waco's leaders, because I cover a 31 county region and I religiously have followed everything that's happening. And I can say that our neighboring counties turn to McLennan County and they will say, McLennan County has put the shelter in place order, McLennan County has put the mask ordinance, and it's always referencing to what McLennan County is doing. I definitely think we definitely had a head start. They've been completely transparent and have worked tirelessly to communicate to the community in such complex and fluid times. And so I am very proud to be a Waco native and to get to observe what's happening around this 31 county region, and to see that comparison of what is happening, because we are taking measures, because we are communicating, they are communicating, and our teams, our leaders here in Waco are working so hard to keep everyone informed. So I'm very grateful for that.
I want to second what Paula said. I think we do have a wonderful community that has really come together at all levels to try to look for solutions, and it makes you really proud to be here. I also want to second what Mariela said, and that was kind of my hope with this conversation, is to start to put out there some of the concerns, but really want to listen more. I think up to this point, we have a small group of people trying to make decisions, but we know that solutions work best when people are part of the solution, and when people are heard about what works for them instead of being told from the outside what should work. So listening to our communities more, which is hard right now in pandemic times to go out in the community, but finding ways to do that. And I'm grateful for this platform to have a chance to try to reach more of our community members, let them know this is an issue, let them know we need to hear people's voices that are being affected by inequity, so that we can start trying to find solutions for them. And as a final thought, let's not also forget mental health. It's huge right now. It's always been huge, and it's very important for people's physical health, and it's important, and it plays a role in everything. And with the pandemic, there's definitely been a worsening of people's emotional and mental health, and we need the community to come together to support us on that as well. And community health workers have an important role that they can contribute with improving mental health in our community. So I hope that we continue to have these conversations.
Thank you all. I am grateful for your time this evening, and we as a community are grateful for your perspectives in sharing today and for your commitment to this important work. But what I'm hearing is, yes, the value of community engagement and ongoing solutions-driven conversation. So thank you so much for that. I want to pivot just a moment to introduce another speaker for this evening who's going to bring forth some information. I'd like to introduce Natalie Mora. She's pastor of Community and Spanish Ministries at Park Lake Drive Baptist Church and intern at the Center for Church and Community Impact, or C3I, at the Garland School of Social Work. In her role at Park Lake Baptist, Natalie is involved in creating awareness about how inequities impact our city and how communities of faith can promote positive change. Natalie?
Thank you, Tiffany. So what should we do with the information that we have heard? What is our calling or our call to action as people of faith? I would say that the call is the same one that we've had since being called to be part of the people of God, which is to love God with all our heart, with all our soul, with all our strength, with all our mind, and to love our neighbor as ourselves. In the story of the Good Samaritan, a young rich man asks Jesus who his neighbor is. And Jesus goes on to explain who our neighbor is and what it means to love our neighbor as ourselves. And this parable tells of a man who is robbed, who's beaten, who's left half dead beside the road, and a Jewish priest, and then a Levite who was an active religious laymen pass by and they come upon the man and they continue on their way. A Samaritan, however, stops and he helps the injured man, who we may assume is a Jew. Now, Samaritans and Jews had been enemies for 500 years. Making the Samaritan the good neighbor in this parable was radical, added a lot of impact. You see, the Samaritan interrupted his journey. He went out of his way to help the injured Jew. He took him to an inn. He stayed with him. And when he left the inn, he gave the innkeeper enough money to provide for the health care of the injured man. So which one of these three, Jesus asked this man, do you think was a neighbor of the man who fell into the hands of the robbers? And the Jew replies, it was the Samaritan. See, Jesus goes on and tells him, go and do likewise. So, what is our call to action as people of faith? It's to be good neighbors. It's to care for equity in our neighborhood, in our community, in our county. Caring for healthcare equity is about compassion and love and the willingness to live as the Son of God said we should, just loving God and loving our neighbor, being educators and advocates, as our panelists mentioned today. So I leave you with this question. As people of faith, if others had to rate you, how high would they rate your involvement on a scale of 1 to 10 in healthcare equity? Would you be the Samaritan in this story, or would you be those two religious men that passed along the way? Cuevas, I pass it along to you.
Thank you so much, Natalie. And thank you all, attendees, panelists, our moderators, our speakers. Thank you all for being willing to join us this evening for Envisioning Equity. Whereas as the Department of External Affairs here at Baylor, we seek to be that good neighbor. We seek to have the conversation and to build the bridges between the Baylor University and the Waco community. And this is one of many efforts to do so. So again, thank you all for your participation. There are several things that are up and coming that we want to make sure you are aware of, just to keep in your calendar and just to ensure that we can continue these conversations and we continue doing our part to be good neighbors in the Waco community. The first of which is on next week, we have Envisioning Equity again, however it will be in Spanish. And so we are asking for whoever in your network that you may feel as if are predominantly Spanish speakers, we're asking that you share this opportunity to join in and listen in again into Envisioning Equity. Next, as many people mentioned this evening, mental health is a big issue in our community. And so upcoming, we have the Gil Taylor Behavioral Health series. You see the link right there. And so we want to make sure that you all are aware of it, and that if you have any questions, feel free to reach out to our office to see how you can register. And we just want to make sure that you're staying connected with Solid Gold Neighbor and staying connected with our office to be aware of our upcoming Envisioning Equity series, the next happening in November, on November 12th, where we'll be looking into envisioning equity education. Again, we thank you all for joining us this evening. We thank you all for participating. We thank you all for the good neighbors you are. And we look forward to connecting with you and building with you as we move forward. Have a great evening.